Hello, and welcome to part 3 of facial bone anatomy. We'll begin part 3 talking about the bony nasal septum and the vomer. So the midline structures of the nasal cavity are called the nasal septum. The ethmoid and the vomer form the bony nasal septum. And specifically, the septum is formed superiorly by the perpendicular plate of the ethmoid bone, which you can see here in pink, and inferiorly by the single vomer bone, which you can see here in orange. Anteriorly, the nasal septum is made up of cartilage and is simply called the septal cartilage. So let's talk a bit more about the vomer. The vomer is one of the single facial bones. It does not have a partner. And the vomer, which means plowshare, in case you were wondering, is a thin triangular bone that forms the inferior and posterior part of the nasal septum. The surfaces of the vomer are marked by small furrow-like depressions for blood vessels, which are the source of your nosebleed when you have trauma to the nasal area. A deviated nasal septum describes the clinical condition where the nasal septum is displaced laterally from the midline of the nose. This deviation usually occurs at the site of junction between the septal cartilage and the vomer. So again, if you have a deviated septum, it usually takes place right about here, and that simply means that the septum is deviated laterally to the right or to the left. A severe deviation can entirely block the nasal passageway, making breathing through the nose impossible. The vomer articulates with two cranial bones, the sphenoid, and you can see that relationship right here because this is the sphenoid sinus. Here's your sella turcica. And then, of course, the ethmoid. The vomer also articulates with four facial bones, the right and left palatine bones, and the right and left maxilla. The vomer also articulates with the septal cartilage. All right, let's talk about the mandible. The last and largest facial bone is the lower jaw or the mandible. It is the only movable bone in the adult skull. This large facial bone is one single bone in an adult, but it originates from two separate bones, and those two bones in the infant join to become one bone at approximately 1 year of age. So let's talk about the lateral view first. The gonian angle, which you can see right about here, divides each half of the mandible into two parts. The anterior part of the mandible is called the body. So this part here is the body of the mandible. The superior part, or the part above the gonian angle, is known as the ramus. Because the mandible is a single bone, the body extends from the left gonian angle all the way to the right gonian angle, or vice versa. The lower teeth are actually rooted in the mandible, and it has an alveolar process or ridge that extends along the entire upper portion of the body of the mandible. Remember, that's just like the maxilla. So if we look at our diagram here, remember the maxilla had an alveolar process on the bottom of its body? The mandible is the same way. On the top of its body, it also has an alveolar process, and that's where our teeth live. Looking at the frontal view, you can see that the single body forms from each lateral half and unites in the midline. So in other words, this is my right half, this is my left half, and at about 1 year of age, they join in the midline. This union is called the symphysis of the mandible or the symphysis menti. The flat triangular area below the symphysis is marked by two knob-like protuberances that project forward. And these are called the mental protuberance. And you can see that here on the lateral, just two little bumps. The center of the mental protuberance is described as the mental point. And remember, we use that for positioning. That forms part of our MML line, our mento-meatal line. Mentum and mental are actually Latin words that refer to the general area known as the chin. The mental point is a specific point on the chin, whereas the mentum is the entire area. Not really important that you know the difference. Located on each half of the body of the mandible is the mental foramina. And you can see that here, that's these two little dots here, and you can see it's a little dot right there. These foramina serve as passageways for the mental artery, the vein, and the nerve that serve the lower lip and the chin. Let's talk about the ramus a little bit more. Remember, the ramus is the superior part above the gonian angle. The upper portion of each ramus terminates in a U-shaped notch termed the mandibular notch. You can see that here. At the end of each mandibular notch is a process. The process at the anterior end of the mandibular notch is the coronoid process, right here. This process does not articulate with another bone and can't be palpated easily because it lies just below the zygomatic arch, and its function is to serve as a site for muscle attachment. The posterior process of the upper ramus is termed the condyloid process, and it actually consists of two different parts. So here's our condyloid process. The rounded end of the condyloid process is the condyle, or the head. That's what you see here. Whereas the constricted area below the condyle is called the neck. The condyle of the condyloid process fits into the temporomandibular fossa, and we talked about that in skull anatomy, but that joint forms the temporomandibular joint. And you can see that relationship here. So the zygomatic process of the temporal bone has a fossa, and the condyle of the mandible sits in that fossa, and that forms our TMJ joint. We're going to talk more about that just in a minute, but look at its proximity to the EAM. So the TMJ joint sits right in front of EAM. So how are we going to remember coronoid process of the mandible and not confuse it with coracoid, for example? Remember, coracoid is in the scapula. So one trick to remember coronoid is to associate the N in coronoid with the N in mandible, or the N in ulna if you're trying to remember elbow anatomy. So that's a good trick. So here is an SMV projection, submento vertex, and we can see the mandible very nicely on the SMV projection. The mandible is a fairly thin structure, making it easily susceptible to fracture. And remember, the mandibular condyle is the part that should be anterior to the petrous ridges on a correctly positioned SMV. So in other words, here are the condyles. They should be anterior to the petrous ridges. Next, let's talk a little bit more about that TMJ joint. The TMJ is the only movable joint in the skull. Remember, the TMJ is formed by the condyle, or the head of the condyloid process of the mandible, as it fits into the temporomandibular fossa of the temporal bone. And the TMJ joint, as I said earlier, is located just anterior to the EAM. The temporomandibular joint is classified as a synovial joint that is actually divided into an upper and lower synovial cavities by a singular articular fibrous disc. So you can see that here. And this isn't really that important for us to know, but just know that this is a synovial joint and it's divided into two parts by this articular disc. A series of strong ligaments join the condylar neck, the ramus, and the gonian of the mandible to the lower borders of the zygomatic process of the temporal bone. And this two-part synovial joint allows for not only a hinge type motion, but also a gliding motion. The action of this type of joint is actually very complex, and two movements are predominant. When the mouth opens, the condyle and the fibrocartilage move forward. And at the same time, the condyle revolves around the fibrocartilage. Therefore, the TMJ is classified as a bicondylar joint, similar to the knee. So when you x-ray TMJs, you always do two projections on the affected side. In one projection, you have the patient's mouth closed, and in the other projection, you have the patient open their mouth. And notice when the mouth is opened widely, as you see here on the left, the condyle moves forward to the front edge of the fossa. So let me point that out for you. This right here is the temporomandibular fossa, that it's part of the temporal bone. Here is the condyle of the mandible, and notice how it slides forward when you open your mouth. If the condyle slips too far forward, it can actually dislocate your TMJ joint. And if the TMJ dislocates either by force or by jaw motion, it can be very difficult or impossible to close your mouth. Remember, closing your mouth returns the condyle to its normal position, and that's what you can see here. So notice the black arrow is pointing to the temporomandibular fossa, and the condyle of the mandible is sitting in its normal position. So again, you always take two projections, one open mouth, one closed mouth, and this is called the Schuler method. Okay, before we conclude, let's talk about joint classifications. So there are two types of fibrous joints involving the skull, both of which are synarthroidal or immovable. The first are the sutures between the cranial bones, and we discussed that in a separate lecture. The second, however, are the joints involving the teeth with the mandible and the maxilla. These joints are described as synarthroidal and are from the fibrous gomphosis subclass. And I don't need you to know the subclass, just know that the teeth that sit within the maxilla and the mandible are synarthroidal. Specifically, when we're talking about these joints, we're talking about the joint between the roots of the teeth and the alveolar processes of the maxilla and the mandible. So you can see here that the sutures of the skull, which we talked about in a previous lecture, are fibrous and synarthroidal. The alveoli and the teeth are fibrous and synarthroidal. Different subclass, but you don't need to know that. And the TMJs are synovial and diarthroidal and are further classified as bicondylar. Okay, this concludes our facial bone anatomy. If you have any questions, please let me know.